We then realized that it may not be a good idea and not possible to go to different places and do the programs every time. So we started with the e-learning, starting off with the free YouTube videos. And there are over 400 videos which are available freely in that perspective. And these videos basically are accessible to across the globe. And a lot of people have been accessing these videos over this time. And as we are looking at currently, there are a lot of people who are subscribing even to this program as well. So there are over 1.5 million views which have been given in these videos in terms of this e-learning program. We then realized that we needed to have a structured program rather than just having some videos. So we started off first with a fellowship program from 2017. And till date in the Regency Center of Diabetes Endocrinology and Research, we have had 11 fellows who have been involved. And I remember Dr. Kapoor, when we went for the first time, and he said that, yes, we should start the program. It was one of the few centers which started the program at that point of time. So in the last 7 years, continuously, we have got very good fellows and with good support from the hospital. In 2018, we started the online learning portal MedEClasses, and then a lot of books and application came up. So we have got pediatric endocrine learning tools. We have got fellowship programs in pediatric endocrinology, a 2-year course. And many of the people who are here actually are part of that course. They are coming 4 times in a 2-year period to gain experience, clinical, as well as learning in that perspective. We have developed the MedEClasses endocrinology app, which I was talking about. It's the most downloaded pediatric endocrinology app with over 5,000 installs, a lot of publications coming onto it. We are working in terms of developing connected clinics, which will help out people develop personalized care in terms of specific disorders. So we have developed tools to guide evaluation for growth failure, which have been validated. There are tools for management of diabetic ketoacidosis, which have been shown to reduce the complications of DKA. We have developed a bone age application, which provides within 2 minutes a reliable and valid way to assess bone age, which has already been published. A lot of other interpreters are there, which are being published, include our obesity interpreter, our puberty interpreter, as well as thyroid interpreter. So these interpreters are going to make life very easy. You have to enter the values and you will get the right outcome. And they have been validated in a large number of patients in that perspective. We also developed a DSD interpreter. And the next step, which Vibha was talking about, was the bone age assisted interpretation of growth, in which all the pediatricians have to do is to enter some basic information with regards to the child in terms of their age, in terms of their birth weight and other parameters. And then you have to enter about their pubertal status. And then you can either have a manual entry of bone age, or you can have a data which you have to select the sites and get the right data in terms of bone age. Now, this bone age assisted interpretation of growth is a tool we have been using and validating for the last 1 year in our center. And this has been found to be perfect in terms of not only plotting the data, but also getting a lot of interpretation and whether our puberty and growth is going normal or not. So this is going to be probably a way in which we can really screen a large number of normal children, as well as patients who are coming to different pediatricians in terms of school, as well as clinic, to get the right guidance in terms of evaluation and management from that regards. So we've got different courses. We have on-site course. So we have had 7 on-site courses till now. And yesterday we had a big number of around 48 participants from across the world actually, and over 300 patients who had come from different parts of the country to specifically come and get exposed in this perspective. We have got multiple publications, and we have now coming up today with the 2nd edition of MedEClasses Basic Pediatric Endocrinology. And we know that growth is a common cause of concern, and this is something which is extremely important to evaluate and assess from that perspective. So, so we have this 12-year-old girl with height of 132 and weight is less. Now, growth failure is a common problem, but most children who come to us with growth failure have a physiological cause. So growth failure is a common problem. 2.5% of all children are short. 80% of them have a physiological cause, while 10% will have a significant pathology. So our job as pediatricians is to not do unnecessary workup in these 80% while not missing these 10%. So this is the goal of this first module about careful assessment and management. Now, just roughly, this is a paper which I published a few years ago regarding the growth failure. So growth failure could mostly be physiological or pathological. In physiological, you have got two situations: constitutional delay or familial short stature. So you need short stature is a child who is short for the population. CDGP is a child who is short for the population, but is not short for the bone age. And familial short stature is a child who is short for the population, but not short for the parents. So three questions will really give you 80% answer. Is the child really short? Is the child short for the family? Is the child short for the bone age? And you will get that this is physiological or pathological. Now, the questions you have to answer is it really short stature? Then whether it is physiological or pathological, and then within pathological, the problem could be in the growth plate. So you can have a problem in low birth weight, syndromic association, rickets or skeletal dysplasia, or in the environment. So your growth plate is normal, but either the hormones are not there or nutrition is not there. So next question is it nutritional or endocrine? If you answer these questions, your work is nearly done in that perspective. So what really is short stature? How do you define short stature? So we can use a statistical definition, but then everybody who is below the third centile will become short. So what we try to look at is at what level of short stature do you have pathologies coming up in this regards. So what we found is that if you are less than -2 standard deviation score, or you're more than -2 standard deviation score, the chances of pathology is only 2%. If somebody is -2 to -3, the chance goes to 40%. Below -3, it becomes 80%. So if you have to evaluate anybody who is less than -3, immediate evaluation is required. -2 to -3, maybe you can wait and watch. And more than -2 standard deviation score, don't worry at all. Now, for people who are more accustomed in terms of percentile, if your percentile is less than first percentile, that is somewhere going around the 3 SDS mark, and third percentile is going more towards the 2 SDS mark. So in a growth chart, and we have also validated that the IAP growth charts are working very well compared to the WHO or the previous Dr. K.N. Agarwal's chart. So these are our field trials as well as clinical trials which we have published have shown that IAP charts are very good. So use IAP chart, plot the chart. If the child is very short, the child is coming out here, height below the first percentile, he needs evaluation. If the child is just below the third centile but not very short, better to follow up for some time. If the child is drifting away, that means short and not growing. If you want an objective definition, if the height is between first and third percentile and growth velocity is less than 25th percentile, requires evaluation. But sometimes children who are not even short require evaluation. So if you look at this child, he was growing very tall. And now all of a sudden his height is coming down. So what you're seeing is that this child is not growing at all, which means crossing of 2 or more percentile lines between the age of 2 years and puberty. So very short, short and not growing at all. This is where your evaluation is indicated. Now, the next question is it pathological or physiological? You have to look at growth chart, pubertal status, and bone age. These three things will give you a clue. So in a growth chart, what you want to look at is what is the absolute status? What is the percentile of the chart? Or better would be standard deviation score. We prefer SDS because this provides us a better objective assessment of growth failure. Then what are the parental expectations? We want to look at in terms of target height. And we know that target height is mother's height plus father's height divided by 2 plus 6.5 centimeters for boys and minus 6.5 centimeters for girls. And we can have SDS scores as well. And then we want to assess whether it is nutritional or endocrine. If you have a child who is short and plump, weight is less affected, height is more affected, this is an endocrine cause. While if you have weight more affected, this is a nutritional cause. So when I say nutritional, it means celiac disease, malabsorption, tuberculosis, RTA, while endocrine could be hypothyroidism, growth hormone deficiency, pseudohypoparathyroidism. So the most important thing to look at in a short child is actually the weight and not the height, which will tell you which way to go. So height, age, and weight age will give you a clue. We have developed a growth interpreter which provides accurate estimation about what's the current status and how do you reach a particular diagnosis. Very importantly, you have to look at the pubertal status and remember two stages, breast stage 2, from where you expect 20 centimeters of growth, and breast stage 4, from where you expect 10 centimeters of growth. If somebody has menarche, only 5 centimeters. So as I always say, if you have a girl with 130 centimeters at B2, you can expect 150. At B4, that will be 140. And menarche will be only 135. So without doing a pubertal assessment, you cannot really prognosticate where the girl is going to land up in terms of height. In boys, the most important thing is testicular enlargement. So testicular volume above 4 ml and growth spurt happens after 10 ml is important. Now, the next most important thing is the bone age. Unfortunately, most pediatricians are not adept at doing a good bone age, and most radiologists are worst because they will give even more confusing reports in terms of bone age. So the most important thing to look at in bone age actually is not the carpal bones, it is the distal bones, because the maturation happens from proximal to distal and fusion happens from distal to proximal. So if you want to assess your radius, ulna, carpal, it will be too late to assess. Very early, maybe carpal will have a role. Otherwise, you are mainly looking in terms of the long bone. And what we are looking at is the comparison of epiphysis and metaphysis. What is the size? So bone age assessment, you want an X-ray which has a full hand with spread fingers with proper exposure. And at different age groups, you can use different bones. This is just a rough guide. Most children between 3 to 12 years, you will compare the metaphysis to epiphysis, and this will give you a clue if it's small, big, or large to calculate the bone age. Now, we have got detailed bone age videos also, which are available on YouTube for over an hour also. You can have a look at that. So, but this is a very basic idea on that. Now, the conventional methods for bone age, including Grulich pile, Tanner Whitehouse, and the automated measures are not easily available to pediatricians because they need expertise, they need time, and they need money. Bone expert will need money. So we have developed a bone age application which really provides a very simplified bone age assessment by comparison of the 5 sites of bone age. And this we have published and we have found it to be very effective. And it gives around 2 minutes, you will get the bone age. And this has been published even for DNB students who have done a very reliable parameter. So this is something which is available in our mobile application. Now, once you know this is basically a short stature, next question is it CDGP or is it familial short stature? So if the child is short for the population, but is not short for the family, then you have a familial short stature. If the child is short for the population, but is not short for the bone age, this clearly means that this is a constitutional delay of puberty and growth. So family and bone age will give you a clue in this regards. And then if it's primary or secondary, look for the facies, look for the body proportions, you will get the diagnosis. And finally, nutritional versus endocrine. As I said, if you have this picture, weight more affected, this is nutritional. If you have this picture, height more affected, this is endocrine. And we have shown BMI standard deviation score below -1 is nutritional, above -1 is endocrine in most cases. So this is something which is important clue in that regards. Now, how do we go about? Look at the growth chart, puberty and bone age, look for faces and proportions, birth weight, very important whether this is a SGA child. All girls in which you don't find a cause do a karyotype to identify Turner syndrome, genetics rarely, skeletal survey, and after everything is normal, you look at liver, kidney, celiac is a very, very important thing to look at, and blood gas in young children. Children below 3 years with growth failure should always have a blood gas to rule out RTA. After 3 years, do a blood gas only if you have features of RTA like rickets or acidotic breathing in that regards. And then, of course, thyroid growth hormone should be done only at a later stage. So all people should have a CBC, ALT, creatinine, TTG, thyroid profile. If needed, you can do karyotype if everything is normal in girls, and blood gas below 3 years of age. This is the recommendation that we have. And calprotectin for inflammatory bowel disease above 10 years of age. Growth hormone IGF assessment should be done only after you have excluded everything. And remember, growth hormone is a pulsatile hormone. Never do a basal growth hormone. That's a waste of money. Do a growth hormone stimulation test if you want to do a good diagnosis, and you may need to do priming in certain scenarios. IGF-1 and IGF-BP3 are markers, but they are not very good markers, so we don't do it routinely in terms of initial assessment. They are screening tests in that perspective. So how do we approach growth failure? We have developed an algorithm which is simplified, which saves cost. So first look at height SDS. Above -2, reassured. This is normal. -2 to -3, next question, short for the family. Yes, you need to evaluate, not short for the family. This is familial. Next stage, is he short for the bone age? If it's not there, this is CDGP. Otherwise, then you need to start evaluation. Then you do screening test. And if screening tests are normal and everything is there, he is not growing at all, then only you go ahead in terms of evaluation, do a karyotype, and after all that, do a growth hormone stimulation test. So this protocol is largely clinical. It is looking at puberty. It is looking at bone age. It is looking at some basic tests and doing complicated tests only at a very, very late stage. So this is how we want to go ahead in terms of evaluation for this assessment in terms of growth failure and identify the cause from that regards. Based upon that, because this looks a bit complicated, we have developed an algorithm which published in JPEM, where we found that we had a 98% concordance with clinical diagnosis using the mobile application from that regards. So having set the background, we'll now go through the cases. Dr. Alapan, you can start off with.
So good afternoon, everyone. Our first case is a 12-year-old girl presented with height of 132 centimeter and weight of 28 kg. Our father height was 164 centimeter and mother's height was 151 centimeter. So Dr. Vijay sir, I would like to know how to proceed further in this case.
Yes, thank you. Though these are the numbers, I would like to plot these numbers on the growth chart, please. Yes. So now what I can see here, that this is a 12-year-old girl. Height was 132 centimeter, weight is 28 kg. Father height is 164 and maternal height, mother height is 151. So if I'm going to see the two parameters first for the particular child in terms of height, age and weight age, then they are corresponding to the same. That is about 9 years of age we can see here. Second, that what we can see, whether this child initially was looking short on the growth parameters on this growth chart, but whether it is really short. So if we are going to see that there is no fixed number, so mid parental height is 151 centimeter. And we all know that there is a range. There is no fixed number. So plus minus 6 centimeter of 151. So it came to be 145 to 157. So if we are going to extrapolate the findings, we can see that this 12-year-old girl is looking short, maybe looking short for the population, but she is growing very well according to mid-parental expectation. So I don't do any investigation. Rather, if there is concern, then I'll do the follow-up and counsel the family. Then whatever you are doing, it is right. And we will see after another 6 months.
So sir has explained excellently that this is a case of a familial short stature which require follow-up but doesn't require any intervention at that particular point of time. On further follow-up, for the last 6 months, her height was 135 centimeter with a growth velocity of 7 centimeter per.
Yes.
With a growth velocity of 7 centimeter per year. And now this is the growth velocity curve, as you can see. Sir, I would like to know your opinion about the further growth of this child.
Yes. So it is a very good question. So what we expect, that growth velocity is not a fixed number, one. Second, that is what is abnormal growth velocity. So abnormal growth velocity is not the velocity below 3rd centile, but rather below 25th centile. So it means that growth velocity is more sensitive indicator to assessment of growth or to see the trajectory of the growth. And here I can see that growth velocity of this particular girl child is much more above the 25th centile. So we can assure that your child is doing very well. Whatever you are doing, that should be continued. There is nothing to worry about that. This girl is going to attain the mid-parental expectation, that is the best of genetic potential.
So as explained that after assessing height on the follow-up, we look for the growth velocity also. And if it is more than 25 percentile, we shouldn't bother much about this thing. And in our case, the growth velocity percentile was 50 percentile. So we should.
Okay.
अच्छा उसे कर देते हैं साइड वो नहीं कोई
So
yes. So the practical point is that correct height for the parental expectation. So don't interpret just only with a single height. One. Second, that you have to measure the parental height. वो ऐसा नहीं हो सकता कि माँ अच्छा 5 फुट 2 इंच की हो गई. No. You have to measure the height. If someone is absent, तो जो भी आप इन्वेस्टिगेशन बोल लो वो करा के, और जो एब्सेंट था उसको बोलो कि वो नेक्स्ट टाइम पे जो आपका जनरल ये है टेस्ट है उसके साथ हुआ जाए. So you will be in a better position to evaluate the mid-parental height. And then if you are going to see, so you can see that growth velocity is the crucial, and that is the most sensitive indicator for the growth, not the absolute height. So this is the take point.
So moving on to the next case, a 13-year-old boy having height of 135 centimeter and weight of 30 kg. His father height was 169 centimeter and mother height was 156 centimeter. Dr. Ayesha ma'am, I would like to know your opinion regarding this case.
So the same thing I would like to reinforce, that whenever you encounter a child who comes to you with short stature, the first thing should be that you should plot his or her height on gender specific IAP growth charts. Okay. So as you can see, both height and talking about height is below the 3rd centile on the lower side, while weight is not affected that much. So the second step should always be, you should plot the mid-parental height along with the range. Okay, so whenever the height is on the lower side, so you always have to look whether the child is short for the family or not. And always keep in mind, again, the same thing, you have to look at the child, whether there are not any clinical pointers in the history or the examination which suggest any kind of syndrome. So this we are talking about in a child who has nothing else apart from a short height. So the mid-parental height is roughly about 169, I think. 169.
Yes, 169.
And the height age, definitely, he's a 13-year-old child and adolescent, and the height age and the weight age, they are affected, but at the same point. And the testicular volume is just 3 ml. So still at a point, we expect him to land up into puberty, but still we have a year to label him as testicular, as a pubertal delay, because we label it till 14 years. So you just have to see.
I think we have residents also here. So maybe Dr. Ayesha, you can just explain about the height age, weightage concept, because that is something which is very important.
Okay. So height age and weightage is basically you compare what the child's height is against what is expected for that age. Okay. So height age means this child is on chronological age. If you say he's 13-year-old, so it's on the lower side. So what you do, you draw a horizontal line where it crosses the 50th centile and drop a perpendicular to know about the height age. So height age is coming at same, it's 9 years, 9 years. And also the weight age, the same thing you do for weight year. So as it was very correctly pointed out, if both things are affected, like height and weight, both are coming at the same thing, that goes maybe in favor of nutritional causes. While if there is any discrepancy, if like height is affected more as compared to the weight, so you have to always think of endocrine causes in such a situation. So that is the importance of plotting height age. You have to see what the person's height and weight is falling along both centiles.
So the father workup has been done, and
so
the
this is-
screening tests were normal. Someone did a basal growth hormone level. which was low. So, ma'am, do you think this child requires the basal growth hormone assessment in this
So
scenario?
talking about workups, you always have to start in a tier-wise manner. So you always send the first line investigations. So in this case, everything was normal. So somebody ordered a basal growth hormone. So here I would like to say basal growth hormone, as it was very rightly pointed out, it has a single value has got no importance at all. So either it has to be a stimulated test always. Okay, so basal growth hormone, even on the low side, does not carry any value because it has pulsatile nature in secretion. So you cannot really comment upon based on a single reading.
As
So
ma'am
growth
has
hormone.
As ma'am has explained that basal growth hormone level, a single value of basal growth hormone level has no implication. The growth hormone stimulation test showing a peak growth hormone of 6.2.
This is also on the lower side.
Now,
So here the catch is, so this I was talking about growth hormone and stimulation. So now look at the age. So there is a slight difference, like in young children, you can go for growth hormone stimulation test wherever you suspect growth hormone deficiency. But in peripubertal children, there is a role of priming. So you have to prime them. Like there are many cases of CTGP who may show, even on stimulation, may show falsely low levels. So you have to prime them before going for growth hormone stimulation test, prime them with testosterone in males and estrogen in females, and they may have a good value after that. So we did priming, and the peak growth hormone was very well within normal range. So this is a take-home message. In peripubertal children, they have to be primed with steroids before going for growth hormone stimulation test.
And if you just look at this growth chart, maybe all of you can have a look, you see this child is just below the growth chart. If it was really growth hormone deficiency, the height would have been much, much below. 99.9% of these boys who are prepubertal at this growth chart will not have GHD. So don't really think of GHD, think of common causes.
So always,
yeah.
That caused the importance for always checking for standard deviation scores, always. So that gives you a clue how far the child is lagging behind. So more than 3, as sir said, definitely. So the lesser the SD scores, more the chances the child may have any pathology, significant pathology.
And if I just go back to what I was talking about, he's short for the population. He's short for the family. But the yellow dot, you can see, we have plotted the yellow dot at the bone age. He is not short for the bone age. So unless he meets these 3 criteria, you will not call it pathological. This is the physiological form. This is constitutional delay. And unfortunately, if you don't do a prime sample, you will have a low GH, which is of no consequence. And he will continue to grow normal. Yes. So priming, sex steroid priming basically means that people have seen that if a child is prepubertal, his growth hormone levels are low. But once they enter puberty, the growth hormone levels increase. So if you have a child who is prepubertal like this boy, if you do growth hormone stimulation, it may be normal. It may be low, but he is normal. So in that case, best to give him testosterone, or girls, you give estrogen before to really check for the growth hormone level. This requires a lot of evaluation. So ideally, growth hormone stimulation should be done by centers who are managing that. But you need to have an idea that don't do a basal growth hormone and don't do an unprimed sample in this regards.
Okay, so moving on to the next case, a 15-month-old girl with a birth weight of 4 kg, mid-parental height was 150 centimeter, failure to thrive, and diagnosed as RTA. Arpita ma'am, I would like to know your opinion regarding this.
Right. Thank you, Alapan. So this is a 15-month-old girl with a bigger child. So she was LGA to start with, while the MPH was not very high. So I would like to go back to the antenatal history and look for any evidence of gestational diabetes, or in the mother, the history I would like to know. And then the investigations, what were the base X's and...
Okay, so the growth chart, as you can see in this child, the growth trajectories are followed, and there was a normal investigations, routine investigations were normal, and as diagnosed was RTA, so someone did a BBG level, so base excess was -7.
Right. So it was just mild acidosis, and it was labeled as RTAs. The thing which we have to highlight here is that the baby was LGA, so the size at birth is determined by the environment, and the size at adulthood is determined by the genetics, and the switchover somewhere occurs at 2 years of age. So the point that the child was crossing the centiles and was labeled as failure to thrive was actually physiological in this child, and it was a normal catch down growth which is happening. So it was a normal physiology which was wrongly labeled as a pathology, and this child did not need any evaluation, and this is a normal catch down growth which usually happens in an infant of diabetic mother.
So as Dr. Arpita has mentioned, this child was destined to be short, but was born large because of environment. And this common finding is not going to be of much change. Don't worry about this. So don't do unnecessary workup in this regard. So we are missing physiology and making it as a pathology.
So again, the practical points as explained by ma'am. Now the next case, case number 4, 10-year-old girl with height of 120 centimeter and weight of 15 kg and diagnosed as growth hormone deficiency. Dr. Arpita ma'am, I would like to know your opinion on this. Okay, so growth chart is here.
So here we can see that the weight age is more affected than the height age. So it points towards a nutritional cause of short stature. So we'll go for the routine investigations and also for the TTG to look at celiac and malnutrition like conditions. So can I have the report?
Yes, so we have done the routine investigations which appeared normal, and TTG level of 12 with karyotype of 46XX. And IGF level was done, which seems to be a bit low. And again, the basal growth hormone level was 0.5.
Okay. So actually in a malnourished child, IGF levels have no value. So this does not hold any value. And we know that basal growth hormone also does not have any value because the TTG was not very high. We could have gone for a total IGA.
Yes.
If IGA is also low, it can be falsely low in this patient. So
growth chart, please. So I just want the residents to have a look at this growth chart. Which thing is more affected here? Is it the height or the weight? What is more affected in the growth chart? Height or weight? Louder? Weight. So this cannot be an endocrine pattern growth failure. So before you reach a diagnosis based upon investigations, look at what you are seeing on the growth chart. The most important investigation in a child with short stature is actually the growth chart. So this chart, just put in your mind, this is not GHD. And very nicely, Dr. Arpita said, this looks like celiac. So why are we asking for IGA, Dr. Arpita?
So if the total IGA is also low, so this may be falsely...
Yes, so around 10% children who have celiac disease are IGA deficient. So if you do a TTG, which is also a IGA, may be falsely negative in that. That is why Western guidelines say do IGA in everybody. But then the cost will come too much. So if the TTG is normal and you have clinical features, then you do a IGA level. Okay.
Okay, so as ma'am has explained that IGF level is dependent on age, nutritional factor, and we should not straightaway go with the IGF level before going up other normal screening investigation. And in this child, the IGA level was undetectable. So also we have ordered for an duodenal biopsy, which shows villus atrophy. So I think the diagnosis is clear from here, and the child was advised as a gluten-free diet in the diagnosis of celiac disease. So the practical points, ma'am, you would like to highlight in this case?
So we need to look at the nutritional cause for the short stature if the weight is more affected than the height age, and IGA should be ordered if the if the TTG is falsely low, and IGF levels are not actually required in a malnourished and a young child, and there is no role of basal growth hormone levels.
So moving on to the next case, a 8-year-old boy presented with height of 100 centimeter, weight of 18 kg. This times he was diagnosed as celiac disease. Dr. Vijay sir, I would like to know. So I am repeating again the case 5. Okay, I'll just sing. So 8-year boy with height of 100 centimeter, weight of 18 kg, diagnosed as celiac disease. And this is the growth chart of this child. So do you think this is a celiac disease?
No, again, the basic thing is that we have to plot these numbers and we have to interpret it. So what we are going to see that what is the most affected parameter, that is height is. So both things are affected, height is as well as weight is, but the most affected parameter is height is. So in case of relatively maintained weight and the predominant deceleration or predominant problem is height, it means that it is this short stature is going to be an endocrinal problem. So in one line, what I want to say you in a very simple word, that छोटा और मोटा बच्चा अगर है, so it means that your antenna should be alerted and you have to dig out all the history. Again, you have to evaluate the child, and according to that, you have to find out that what is the cause of this reduced height is, and accordingly, we have to plan for this. So I want to see the first systemic parameters, and then yes. So I can see here that hemoglobin is normal, a normal creatinine and a normal liver function test. TSS is also normal. TTG, a bit I am skeptic for this number, but growth hormone, this is a single digit. I want to do one, that is bone age first, and the second, that is growth hormone, that is dynamic stimulation growth hormone tests.
So there was no effect on gluten-free diet in this child. So he was advised gluten-free diet. And if we have consideration about the height, weight and weightage, sir had explained already that nutritional causes will cause much more effect on the weight rather than height, and the endocrinal cause at the same time will cause much more effect on the height rather than the weight. So weightage and heightage will roughly give you an idea about whether this is an endocrinal pattern or a nutritional pattern of short stature. So further workup, duodenal biopsy was advised in terms
Yes.
of the high, slightly high TTG level, and it was normal.
So just again for residents, that if the things are not clinically correlating, again you have to recheck the things. So doesn't go with number. You have to see the oxology. You have to see the all other. So in total, you have to see. You don't have to see in bits and paper. So you have to, if you really want to solve the puzzle, you have to join all the things together and you have to look at the big picture. So bigger canvas, and you are going to make the diagnosis. So yes, I would like to see the growth hormone stimulation test.
And the peak growth hormone level in the stimulation test was 1.
So yes. So initially we were saying that any growth hormone level beyond 10, but since we are having very good sensitivity method nowadays, so any growth hormone level which is beyond 7 nanogram per ml, then it means that there is no growth hormone deficiency. So if this is 1 picogram per ml, this is really very low. It is severe growth hormone deficiency, and this child will require treatment. So before that, we have to see that why this child is having relative less growth hormone. So we have to see whether there is hypofunctionality of the pituitary or there is some mass effect or something like that. So here we can see that pituitary size is hypoplastic. Why there is hypoplasia? Because if you are going to see, the most volume of your pituitary is going to be devised by anterior pituitary, and even in anterior pituitary, it is mostly devised by somatotrophs, that is growth hormone producing cells. So that's why we can see here that this is the cause, hypoplastic pituitary leading to growth hormone deficiency.
So as the diagnosis of celiac disease, Ispagan has recommended that initially we should go for the TTG level. If it is even negative, then we can go for the IgA level. So if IgA level is positive, then we can further go for the biopsy to confirm the diagnosis. If the TTG level is more than 10 times of the upper limit, then we have another option of endomysial antibody, which is, if it is positive, we can stamp this child as celiac disease. If endomysial antibody is negative, we have to further confirm it by using a biopsy. And if it is between 1 to 10 times of the upper limit of the normal, biopsy, we can confirm the celiac disease by using a biopsy. So moving on to the next case, a 6-year-old boy, height of 90 centimeter and weight of 12 kg, diagnosed as nutritional ricket and given multiple doses of vitamin D. The X-ray is showing features suggestive of rickets, and the baseline investigation is like this. So, Dr. Ayesha ma'am, I would like to know whether you are considering this child as a case of nutritional ricket or not.
Yeah. So this is a very common scenario. We often see children like this. So you can see he looks like a child of rickets with the clinical features, and he has received the dose of vitamin D and calcium, which is expected, and he has not responded to treatment. So if you remember what I had talked yesterday, that in a situation where you have more involvement of the lower limbs, and especially you have a catch here, like the child has not responded to your usual vitamin D and calcium supplementation, to always think of secondary rickets. So which could be calcipenic, which could be hypophosphatemic, or which could be vitamin D resistant rickets, or even because of multiple reasons like RTAs, like renal failure. So always suspect causes of refractory rickets in such a situation. So phosphatemia is very common, but as we can see in the biochemical parameters here, it's within phosphate levels are within normal limit. So the next step would be you have to check for acid ABG analysis to look for whether it could be because of RTA or not.
So
once
ABG
we have
analysis
the
has been
report,
done,
yeah.
and pH was 7.1 with base excess of -15.
Yeah.
With the urine anion positive.
Okay, so result is itself very clear here. So it was actually a case of RTA, and the clinching point here was more involvement of the lower limbs and not responding to your usual treatment. So this was RTA. Then you have to differentiate between the proximal and the distal RTA. So the helpful test would be checking for a urine pH and this bicarb CO2 difference. So urine pH was 6.8. So that goes in favor of distal RTA. And also don't forget to check for features of nephrocalcinosis, because that is more common in distal RTA. So you have to send the investigations accordingly.
Okay, this child has also features of nephrocalcinosis as seen by USG. So the next case, case number 7, a 14-year-old girl with height of 120 centimeter and weight of 32 kg. You can see the child, ma'am. The initial screening investigations were normal. But I would like to know, you would like to inform any test, or you would like to see any further clinical features in this child before proceed.
Okay, so as mentioned already by sir, any short girl presenting to us, any short girl coming to us with growth failure, we have to consider Turner's syndrome as a possibility. And on looking at the child itself, there are pointers clinically for Turner's. If there are no clinical pointers, then too we have to suspect Turner's and order karyotype, an extended karyotype with a 50 metaphase to rule out Turner's, because it may be a mosaic Turner, and an extended karyotype will help us find out the Y cell line, because Turner's may have a Y cell line which may progress to cause gonadoblastoma in the later on period. So this girl, definitely she's a walking Turner's. We have to have a high index of suspicion here and order an extended karyotype along with FSH, which will be supportive in this patient. So
as explained by the ma'am, a short child, girl child especially, with features of Turner's stigmata like widely spaced nipple, brachymetacarpia, waved neck, we should always consider the Turner's syndrome.
So there are,
this is brachymetacarpia is present in the
there is brachymetacarpia in the second one, and there is widely spaced nipples and shield-like chest, and webbing of the neck is also seen in this child.
So karyotype was further ordered, and it was like 45X in this case, and diagnosed as Turner syndrome. So
we need to also screen these girls for other associations. So USG KUB should be done to look at horseshoe kidney and other kidney abnormalities, hearing screening, and most importantly, echo and cardiac MRI should be done in these children, because there are left-sided heart lesions, and which is the most common cause of death in these children. And there is no need for growth hormone stimulation test in children with Turner's. You can straight away go for growth hormone therapy in these children.
okay, so moving on to the next case, a 5-year-old boy with birth weight of 2.1 kg. So as SGA child, having complaints of poor growth but a normal development. His height was 90 centimeter and weight of 10 kg. We can see it in our growth chart. The height is affected, also the weight. Dr. Ayesha ma'am, I would like to know your approach in this case.
Okay. So we have a child which was born small.
Yes.
Okay. So as it was suggested by Dr. Anurag sir, For SGA babies, you have to wait for a particular period of time for 2 years. Most of the babies, 85% of them, they achieve their normal height, while by rest of them, like 5 to 10%, they achieve by at the most by 4 years of age. So you have to wait till then. So we have a 5-year-old boy, and the height you can see is very well below the third centile. So definitely you want this warrants further workup in this child. And okay.
Okay. So
Okay, so what that says is that SGA babies, as I said, 10 to 15%, they will be born small and always remain small. But that is because there is a time period, so you have to wait whether this baby falls in the 85% categories who has a good catch-up growth, provided adequate nutrition has provided, and he carries and goes very well as compared to the normal peer group. But the 15%, they remain short, so you have to wait for that period. And that's what I would like to. So they have maximum catch-up growth by 2 years of age.
yes, yeah. So before leveling as a cast down growth, we have to always wait for some times.
And having a rapid growth is not a good sign here. More chances of having metabolic syndromes and morbidities as they grow older.
Yes. So we have to always wait for at least 2 to 4 years before leveling them as cast down growth, and a rapid growth in this period might predispose them for further complications like metabolic syndrome or precocious puberty in that scenario.
Diabetes later in life.
So the next case, a 10-year-old girl child with height of 112 centimeter and weight of 24 kg. You can see the child. Initial screening investigations were normal. Dr. Vijay sir, I would like to know your approach in this case. What you would like to do further?
Yes, thank you. So please plot on the growth chart. And what I can see with this picture, if you are going to see the dysmorphism is there.
Yes.
And upper to lower segment ratio, if you are going to see, again, this is skewed. So I would like to see other parameters.
So anthropometry has been done, and
Yes.
a short child with upper segment to lower segment ratio is 1.5:1 in a 10-year-old girl child.
Yes. So just I want to see that whether this is abnormal girl. So skeletal survey and other things to rule out skeletal dysplasia will be my priority to see that how the bones are growing.
Alapan, what is the normal upper segment to this age?
At this age, around 1:1 or 0.9:1.
Yes.
Around.
So normally it is like 1.7:1 and it gradually comes down. So this case, what we are seeing is that the upper segment to lower segment ratio is too much.
One. So before jumping into screening investigation and everything, we should always go for the history and the clinical examination as well as anthropometry. I think is the most important part that always should not be overlooked. So in this child, mutation of FGFR mutation has been done. Anyone diagnosis?
This is a walking case. Residents, I think this is very clear. This is achondroplasia.
Achondroplasia is the time. So the next case.
Dr. Alapan, can you go back, please? Just one second. Yes, please. So this was a case conundrum, and just I want to say that before doing these genetic tests also, even parental examination is also must. So पेरेंट्स का फिनोटाइप कैसा है वो भी देखना बहुत जरूरी रहता है, because milder skeletal dysplasia with short stature even can be a presentation. So it is always to again go back with a good clinical examination of the parents also.
So often you will have hypochondroplasia, which is there in the parents. They will have short hand and they will be able to identify that. Very important point by Dr. Vijay. Now, before we wind up towards the next part, we now have a lot of obese children who are coming to us, and obesity is becoming a bigger problem actually. So obesity is more common as compared to short stature. Here, 98% have physiological cause, only 2% have pathology. So you don't want to do workup unnecessary, but this physiological people can actually develop diseases. So as I said, ki obesity is not because of a disease, but it becomes a cause of disease. So this is something which is extremely important to understand. So obesity can be physiological or pathological. Physiological obesity means normal growth, normal puberty, normal development. If your child has normal height, weight, development, think that this is a physiological cause. If there is hyperphagia, vision abnormality, pubertal developmental issues, very early onset, think of genetic obesity, especially before 2 years of age. If there is severe hyperphagia, think of hypothalamic obesity. Endocrine causes are rare, but you have short and plump child. That will be the cause of endocrine cause of growth failure in that regards. So our criteria for evaluation is, if you don't have any obesity criteria, do not do workup. If yes, you go for age less than 5 years, very obese. In that case, you have to do a genetic study. If, however, it's less, then look for syndromic features, development, vision, and dysmorphism. If they are abnormal, go for genetics. If they are normal, look for height. If height is low, do for endocrine workup. If it's normal, complication screening. So your main is clinical first, age and clinical parameter. Then you decide about whether you want to do workup. We have developed an obesity interpreter based upon you put some basic findings, and we have done a validation study which shows a very high rate of concordance, and we found that the interpreter gives the right diagnosis in around 98% of cases in that regards. So we'll start off with the cases of obesity now.
So the next case number 10, 12-year-old boy with obesity, height is 160 centimeter and weight of 70 kg. The height is not as short at this age of child. TSH investigation, someone did the routine screening workup as well as the thyroid profile, and the TSH was 7.91, and he was advised thyroxine in this case. Dr. Ayesha ma'am, I would like to know your opinion regarding
Again, a very
thyroxine.
common scenario and dilemma situation that we frequently encounter, because obesity is so common these days, and every clinician has this habit of sending investigation, especially thyroid, attributing thyroid to be the reason for the child's obesity. And often the result comes like this. So always remember, you don't treat just a single report. You have to see for thyroid hormones, the T4 levels also. So isolated TSH does not make any sense. So you have to look at the hormones. And also remember that in obese, this TSH, high TSH level could be the effect of obesity. The reason being, can you come to the chart, please?
Yes.
Because the obese children, they may have high leptin levels, and this might stimulate the TRH, leading to it falsely elevated. So TSH, a baseline elevated TSH in a child who presents with obesity, is a cause of the obesity itself. So does not warrant any treatment. And one thing I would like to add, like normal physiological obesity, what happens, you will see a child who is obese and also very tall, as compared to the pathological causes or endocrinal causes of obesity, where you will have a child who is obese and short. So keep this thing in mind. So don't treat isolated TSH. This could be very well a result of that. And just you can reassure the family and just follow him up.
Important thing to look at in a short child, I said, was weight. The most important thing to look at in a fat child is the height. If he's tall, it is more likely a exogenous constitutional physiological obesity. If he's short, this is a pathological obesity. Very, very simple message, I think, from Dr. Ayesha, very important message.
So the next case, 12-year-old girl with height of 130 centimeter and weight of 58 kg. The screening tests were done initially, which was normal, and her parents were reassured. So again, he developed rapid weight gain. Dr. Arpita ma'am, I would like to know your opinion whether this reassurance was significant or not.
Right. So in any case of growth failure or growth excess, we need to plot the weight and the height in the growth chart and look at the weight and the height. So as ma'am had already pointed out, any exogenous or physiological obesity will be a tall individual and obese individual. So here we can see that the height is less and she's an obese girl. So this points towards an endocrinal. So as mentioned already, a short and a plump child, we have to think for the endocrinal causes. And if we look at the girl, she has a typical Cushingoid faces with round faces, and she has a buffalo hump also seen. So we have 3 endocrinal causes like hypothyroidism, Cushing's, and pseudo-hypoparathyroidism. This one specifically looks like Cushing's, so we need to go for an overnight dexamethasone suppression test, and it was not suppressed and pointing towards a Cushing's
syndrome. Okay, so the next and the last case, 3-year-old girl with rapid weight gain. Height was 84 centimeter, weight is 26, and she had some severe hyperphagia since birth. Routine investigations were all normal. She had normal development, vision, and infection, no history of any infections. So, sir, I would like to proceed further for this case.
in this case, what I can observe that the rapid gain was started since very early. One. So pathological thing, that is pathological appetite. And again, you can see the other parameters, the normal development, vision and infection. So again, since the insult was started very early, so +3 standard deviation score of this thing in less than 5 years of age child. So genetic study is really required in this. So here, so yes, so I can see here that genetic study was done and leptin was undetectable. So this is a case of leptin deficiency. So it means that all the children who are presented to you with increasing weight doesn't always say that this is a case of simple exogenous obesity. So again, a good history taking, the pointers toward that what time insult has been appreciated, and then accordingly we have to plan and observe the things.
Okay, as Sarah has always said about the 4S, like soon, that means if the obesity is very early onset, severe, syndromic, and segregating, that means there is a family history, or we should always look for the genetic cause. And as in this case, there was severe hyperphagia and early onset of obesity, we should go for the genetic study, and the genetic study showing a leptin deficiency in that scenario. So